Okay, good morning and welcome to the June Digital Health Virtual Program. My name is Matt Rayner. I'm the publisher here at Healthcare Innovation. Today, we kick off the second half of the year of this Digital Health Virtual Series. What's different about the second half of the year versus the first half of the year? Well, in the first half of the year, we spoke what I would say as a big picture about a variety of topics. Starting today and then each month, we're now going to drill down exclusively on one of the core topics and explore deeply the challenges, opportunities, and strategies when it comes to that core topic. And we're very excited because today is all about patient engagement. Officially today is called Patient Engagement Trends and Best Practices. Whether you're tuning in live today on June 23rd or watching this content on demand, thank you for joining us and for being a part of this program. We have 6 fantastic sessions programmed today, a mix of panel discussions and fireside chats. All of today's sessions have been created to be interactive. Our faculty is ready and waiting for your questions. So please do not be shy to submit a question. Simply use the chat function within the Zoom platform. All of today's sessions are being recorded and will be available to watch on demand by the end of the day today. With that said, let's officially kick off the June Digital Health Virtual Program with our opening panel discussion. This panel is on wearables, managing the data and overcoming barriers that come along with them. This session is being moderated by our editor-in-chief, Mark Haglund. And at this time, I'd love to welcome him onto the virtual stage here and kick things over to Mark. So Mark, if you're with us, feel free to take it away.
Thank you so much, Matt. Welcome to everyone. Per what Matt just said just now, welcome to you if you're with us now or in the future, which sounds a little bit Star Trek-y, I know, but it could happen. So welcome everyone. We're so glad you're with us. I am so excited about this session because we're going to get into some areas where things are a little bit confused, exciting but confused, which is great for us for having panel discussions. So I am joined this morning by 2 physician executives, Dr. Robert Hurton and Dr. Nick Patel, and they represent Mount Sinai in New York and Prisma Health in South Carolina. So what I'm going to do first, before we plunge into our discussion, I'm just going to ask both doctors to introduce themselves briefly, their role in their organization and their connection to this topic. So I'll just go in visual order. Dr. Hurton, why don't you begin?
Yeah. Thank you very much for having me here today and for allowing me to join the panel. So I'm a gastroenterologist by training, but really a physician scientist, with much of my time dedicated to research, particularly in the field of novel technologies, but also with a focus in wearable technologies. And I'm a faculty here at our Digital Health Center at Mount Sinai called the Hassel-Plattner Institute for Digital Health, where we've really been working to try to facilitate and grow the ability of our healthcare workers in our health system to really be able to employ and study wearable technology and these new digital tools to kind of advance this field in the future.
Wonderful. Thank you so much, Doctor. Dr. Nick Patel. Welcome.
Thanks, Mark. Great to be here. I'm a practicing internal medicine physician for the past 18 years, and I serve as the Chief Digital Officer and Vice Chair of Clinical Affairs at Prisma Health. Prisma Health is the largest health system here in South Carolina. We span over 50% of the state and have about 30,000 team members. And as Chief Digital Officer, I help lead digital health and innovation focus on next generation of healthcare delivery to enhance the patient experience and improve access, get patients to their healthcare goals by using a connected digital continuum of services that we have put together here. We've done over 700,000 virtual visits since the start of the pandemic, which is up from 22,000 the year before. And as part of that work is driving the use of remote patient monitoring and wearable devices for chronic disease management to get patients to their goal and promote population health. So I'm really looking forward to conversation today around wearables.
Thank you so much, Dr. Patel. Thank you both. You're obviously the perfect persons to speak with on this. I want to begin by doing just a very brief level set. First of all, the term wearables, as Dr. Patel just mentioned, we really should be talking about connected remote devices, patient-facing devices. And because many of them are, for example, a digital scale is not a wearable, but they inhabit this really interesting emerging universe. As we all know, one of the things that happened during the pandemic, or has happened during the pandemic, since it's not completely over, is the need to create remote connections to patients whenever appropriate. And remote care management has really come into its own more and more in the last year and a half. So there's a context there. What's interesting is that there's a little bit of a Wild West, I would say, in terms of development out there. Various types of devices are being created, put on the market by various types of entities, including provider organizations. We have to figure out where these will sit inside our constellation of connectivity between and among clinicians, patients, care managers, and everybody else. So it's exciting, but I think there's probably some confusion and some amount of just kind of wondering out there in the field as to where things are going. So I think what I'd like to do is start with kind of this broad blue sky and ask both of you physicians, where are we? What does this look like? Help fill out this kind of portrait that we're looking at right now. Either of you could go first, whoever would like to go first.
Yeah, Mark, I think that's a great insight. Remote patient monitoring, at least for Prisma Health, is focused around chronic disease management. And we really focus the use of our data to drive which patients need that connected device. Mm-hmm. And so when we look at it, it's not about the next new techie, new sensor or things of that nature, but really, how do we enable patients and engage them more to get them to their goals? And if you look at the prevalence data through CDC for South Carolina, we have a significant amount of heart disease and stroke in this area, as well as diabetes. And so we're focusing our attention around those type of programs around hypertension, diabetes, as well as congestive heart failure to start off with. But to your point, it really needs to be delineated between what patients have, like wearables, like Apple Watches and other things that pick up in retail space, and what is being given out using data at the practice level and the data coming in for that. So we can have a great conversation around the differences between the two and how health systems are tackling that.
Yeah, exactly. Dr. Hurton, how would you characterize this landscape right now?
Yeah, I think you hit on some important points. Before COVID, if you think back a year and a half ago, a lot of this space was, you could say, the wearable space, and how we were practically using it and studying it in medicine was sort of maybe in its infancy. And when COVID sort of came about, you really saw this incredible collaborative push all around the world of people working together to try to push science on multiple fronts and fields. And digital medicine, I think, saw this in a way probably more than any other area, not only with telehealth visits, but also with the study and use of these wearable devices. For example, in COVID identification and prediction, where you start having multiple large studies being done trying to say, can we identify and predict some disease that's out there, in this case, COVID. But you're right, it is a bit of the Wild West, because we have this kind of dichotomy, or these two groups of devices that are sort of out there. So you have commercially available devices like Apple Watches and Fitbits that people love to use, are using very regularly, and can provide data that can be kind of manipulated or used to understand disease and that's going on. And then this other kind of group of these custom devices, whether it's from engineering groups or from smaller startup companies that are also trying to come up with a device that we could get data from. And they both have advantages and disadvantages. You could say commercially available devices, very readily available. People want to use them regularly and continually, but there might be some data access issues.
Yeah.
Custom devices where you might have this uptake where people might not want to use them as often or as much because they're not as, you know, trendy or maybe look as cool, but you could get a lot of data from them. So you have this kind of push and pull, and it's a little unclear sometimes where we're going to settle out in that kind of dichotomy.
Well, I'm so glad you said that because I'm a little unsettled myself. It feels as though, first of all, it's interesting to me because, you know, going back 30 years, you know, for example, if you were a patient and you were going into the cardiac cath lab, of course, you would never bring your own equipment, right? That wouldn't exist. But now we have this piece of our universe where patients could bring devices that they've acquired as consumers on the open market. And of course, those devices aren't regulated by HIPAA or anything. So there's all that whole set of issues. And yet, of course, you also have health system provided devices. For example, many care management programs now are providing Bluetooth enabled weight scales, you know, bathroom scales, even thermometers. I interviewed a physician leader at Sheba Hospital and Medical Center in Tel Aviv, Israel. And at the beginning of COVID, they did something that I thought was just so ingenious at the time. They FedExed or overnighted to their patients a kit that include, and it was all Bluetooth enabled, a bathroom scale, a Bluetooth enabled stethoscope, which I thought was really interesting, a thermometer, and a Bluetooth enabled blood pressure cuff. And then they went on to, you know, went online and did virtual visits with the patients. And the physician would say, well, now, you know, Mrs. Smith, here's how you put the cuff on, and we'll have, you know, have you fill up the pressure. So it was very interesting because there you have a situation where it's coming from the health system. But as you mentioned, that we also have potential ingress from patients' own devices. Doctors, do you think that some of those consumer facing devices that patients are using, where will those fit? Will some health systems and care managers say, yeah, let's try to somehow make use of those? And if so, then what happens? Because there's a whole bunch of process questions around that, right? So I'll have you start, Dr. Hurton, and then Dr. Patel.
Yeah, you know, the best wearable device ultimately becomes the one that's going to be used, that you can reliably have someone wear to kind of accomplish the goal of that device, whether it's long-term disease management or just in a short-term period of time, say like looking for 30-day readmission rates after a specific reason from the hospital. So I think it comes down to, first off, what the goal is of the wearable. If it's long-term management, you need to really be thinking about what someone's going to really wear every day for a year or however long you need them to. Or if it's short-term management, you might want something that'll give you a denser data set to get a lot of rich data and better manage it. And there might be a trade-off in those ways between the two. So some of this comes down to goals too, really, what the goal is of the health system and of the people that are trying to use these devices.
That makes sense. Dr. Nick Patel.
Yeah, I agree with Dr. Hurton. I think you really need to flesh out what your use cases are going to be for the wearable devices. So for example, we're actually using and promoting use of wearable devices such as the Apple Watches and Fitbits for wellness for our own employees. So sometimes, and actually some of our departments and divisions, they're putting in variable comp to say you hit a certain amount of steps. And you again are able to compete against each other as well and promote exercise and wellness. So sometimes it's not about wearing a wearable for chronic disease management, but to keep people healthy and promote that and gamify that and promote maybe incentives to get you to your goal. You see this a lot with some of our business health partnerships that we have where we promote a lot of that as well. And then there's the flip side of that where, okay, now you have someone who has been diagnosed with a certain chronic disease. And then you have to look at it, okay, you have chronic disease, is it stable or unstable? Is it controlled or not controlled? Are you getting to your goal or not? And so you can combine, for example, hypertension with a wearable, because it's not about just pushing pills to a patient because their blood pressure is going up, but to also say, hey, if you need to also increase your exercise and increase your fitness and lose some weight. So as we do that, maybe we go down on your medication because you've lost a lot of weight, your blood pressure's gotten better. So the wearable data, both of them are feeding each other that information. That's very important. So again, it could be a combination of both, but you have to look at what your end goals are, as Dr. Hurton mentioned.
Yeah, exactly. So why don't we have each of you just tell us about your journey so far at your organization, what you've been doing, kind of where you're at, and most of all, as you share that, what your kind of governing principles are, or what your overall strategy is, what you and your colleagues have decided you were going to do. Let's start with you, Dr. Patel, and then we'll go to Dr. Hurton. But tell us about your journey.
Yeah, so it's an interesting one because there are two stories I could probably tell, pre-COVID and post-COVID.
Yeah.
I'll stay with the current state of where we are. Like I said before, we've done a lot of virtual visits, just like any other health system has, and we've had a lot of engagement with our patients, more so than ever before. Now we're trying to engage with patients at home in between those office visits. And I think one thing we all, as physicians, know, it's very hard to get patients to their goal, especially those that are uncontrolled, just seeing them every 3 months or 6 months, et cetera. It's about how do you engage with the patients in between those office visits, what are those digital encounters, right? So what we've done is we set up a digital continuum of services, everything from asynchronous care through automation to chatbots that are centered around hypertension programs that ping you to say, hey, I've noticed your last 3 blood pressures are high. Did you miss a dose? Are you taking your medications, et cetera? Anything a normal triage nurse or provider would ask. And then having that wearable device that's complementing that by feeding that data, but making it very simple for the patient. So Mark, you mentioned something that you heard from a colleague in Israel. Well, that's exactly what we're doing here. So the way we're doing it is we have 2 models. One, you can get it. I'm a provider seeing a patient, identify a patient, but we as health system had identified what the inclusion criteria is for remote patient monitoring, right? So you can't just give it to anyone. You want to try to understand what is your threshold for inclusion, and then what are the alerts and who should be getting those alerts as someone if a threshold is hit. So we give them either in the practice or we identify based on data and ship out a white label box with a blood pressure cuff, a weight scale for our hypertension program, or it could be a BP cuff, a weight scale, and a glucometer for a diabetes program. Or, again, sometimes there's blurring of the lines, but we try to keep our SKUs very minimal. Then we also look at social determinants of health. So does this person have access to broadband? Do they have access to a smart tablet? Because they're going to have to engage somehow. And if they don't have a smart device, well, now we're going to be including a smart device directly connected with all those pre-configured devices in the box. So all you have to do is check your blood pressure once or twice a day, whatever you've been prescribed to do so, and then we get that data. Now, what we've done with that is, if your blood pressure, based on what our clinical content advisory group that we set up says you have hit a threshold, average systolic blood pressure or diastolic blood pressure of a certain number, then potentially you can get a push notification to that tablet, or a chatbot may start asking you those questions that I started with. And then let's just say based on that response, they have negative responses. Then we start a video visit and say, hey, Mark, how are you doing? I noticed your blood pressure is going up. Have you had XYZ symptoms? What can we do to get you to your goal? And sometimes that might be something clinical, or it might be something that requires a PharmD to help that person with their formulary and get the medication that they can afford. So they're more adherent with their regimen. Or it may be a social worker to help them with other needs. So that's how we've thought about it, is have this continuum of services, trying to do as much as we can to emulate what we would normally do in the office setting, but do it at a higher frequency in between those office visits through the digital encounters.
That's wonderful. And real quick follow-up question. How is, who is staffing those in between communications? Is it a care manager nurse in a call center? Is it a care manager nurse who is a part of a physician practice team, or how is that architect?
So great question. And something that we've been thinking about for a while, for the last couple of months. So you'll see a spectrum. So you may have a provider who goes, I want to set up this person to a hypertension program. Dr. Patel, I want you to send the equipment, get everything set up, but I want to handle all the data. I want to tweak the meds, and I'll reach out to them if that happens. The practice will. Then there's some people who want a centralized model. So we also formulating a virtual care hub. So all the data goes through this program where you have certified providers, you have PharmDs, you have care managers, you have social workers, you have the whole team gambit, right? And they manage it, that patient, tweaking those meds up and down, doing those visits if needed, but making sure that data eventually still gets to the primary care provider. So when they do get that office visit, they can see that dashboard and data and go through that with the patient. And we would do all the supply chain and logistics of those devices, getting it out to those
That's
patients.
great. I love the flexibility of that. I think that's very, very smart, the agility. Dr. Hurton, tell us about your organization's journey so far.
Yeah, so in particular, I've been focusing mostly more on the research side. So I've been, before the COVID pandemic, I feel like everything, like Nick had mentioned, pre-COVID and post-COVID is like a different world. Pre-COVID, it was really focusing on how can we leverage wearable technologies and the signatures that we're developing from them to manage chronic diseases better. And as I mentioned, I was a gastroenterologist. I'm a gastroenterologist. And I take care of patients with inflammatory bowel disease, this chronic inflammatory condition of the GI tract. And one of the biggest challenges we have is in this chronic disease, but also in others like rheumatoid arthritis, as an example, is how do we monitor people, at their homes in the home setting for when flare-ups or worsening of the diseases are going to be occurring. And this is very challenging to predict and identify for people suffering from a myriad of these diseases. So our group here has really been trying to leverage the data we can get from wearable devices, both in inflammatory bowel disease, but also in other kind of chronic disease states and other conditions, to say, can we start identifying physiologic markers from these devices that would allow us to really be able to identify and predict disease course or response to the medications that are being used, which would really ultimately result in better disease management. And this has been one difficulty and a challenge is at this point, we still don't have a good understanding, by we, I mean, sort of the medical community of which markers are most important for specific disease states to look at. And then what changes necessarily should trigger some of these visits in these chronic diseases to say, all right, you have a 70% chance of flaring in the next few months. You need to re-engage with your doctor who you maybe haven't seen in like 6 months or 9 months to so we can get ahead of this issue. And this has been something we've been focusing on not only in our own research, but also facilitating in our larger hospital system to say, how can we push the boundaries of this research to really start using these digital tools to better manage diseases that we're otherwise dealing with at point of care visits, say in the doctor's office for 20 minutes every few months. So it sort of breaks down that barrier of the doctor's office to kind of bringing it to the patient's home.
Yeah, that's so great. I have to tell you, I'm sure it's both exciting and probably a little bit nerve-wracking to be on the leading edge sometimes, because when you said, you're still trying to develop the markers, I think that's exactly the leading edge, right? Like if you can figure out a data set that makes sense, that will really propel you forward. So that's wonderful, Doctor. In fact, that leads to my next question that I was going to ask. What are some of the challenges, including around data quality, integration of devices and information systems and what are some of those kind of process challenges that both of you and your teams face? This is where, again, I feel like we're in such an early phase because we haven't figured out what plugs into what yet, right? It's a very, like, how are we going to use data? What is the value of the data? Who's going to analyze the data? And then how are we going to integrate the data into processes, right? So if someone's inflammatory bowel disease is getting worse, like how will we know? And then who will figure out how much worse and what to do? And how will we track and how, right? So all of those So why don't you start, Dr. Hurtner, with data and integration challenges, and then we'll go to Dr. Patel on that.
This is a really good point, because if you're trying to leverage multiple devices, say to reach a larger audience, so say you take everyone with inflammatory bowel disease, say at your hospital system, or rheumatoid arthritis, and you say, all right, let's just use the data that's coming in from people's commercial devices even.
Right.
Well, there's a myriad of different devices, and
Right.
they might not all give the same signatures or sort of be calibrated in the same way. And this becomes a little bit of a challenge when you're trying to then collect the data, analyze it, and say,
you could also have chaos, right? Because if you have 10 different devices on 500 different people, right? Sorry to interrupt. But.
Yeah, no, you're right. So say, steps might be simple. Everything, they might be decent enough at picking up your steps, but we've been looking at markers called heart rate variability, which most of these devices collect, and it measures your autonomic nervous system function. And by looking at nervous system function, it can be a very sensitive predictor or identifier of things going on in the body. But is Fitbit's heart rate variability numbers the same as Apple's? Is that the same as a custom device that we want to study and give out? And this gets to this idea of quality and what you brought up, where it's sort of the Wild West. There's not a standardization of some of these other more nuanced markers. And that can be challenging sometimes when you develop an algorithm on one device and you say, well, is this applicable if I want to start applying it to, another device that my patient might be having?
Right. I mean, you could even get into this humorous situation where you had a patient wearing 3 different devices, measuring the same thing, and then you could study. But of course, then things get a little crazy after a while, right? But I think you brought up a really interesting point. Like Fitbit and Apple might be measuring the same thing. How do you know? I mean, again, in a weird way, you'd have to have Mrs. Smith wearing both at the same time, and then you could kind of compare and see what they're doing. Dr. Patel, I'm glad you smiled at that. Imagine a patient with like 5 devices on them walking around.
Well, I was actually thinking about that patient putting that Fitbit on their dog, having them run around to get their steps in that way.
Right.
So, yeah, I mean, there's so many challenges with this. So let's start with devices. One, you do have to standardize, and to Dr. Hurton's point, that calibration is extremely important. So you have to believe the data that's coming in, and so you want to remove variability as much as you can. What we do is FDA approved devices, and we don't have a whole bunch. We use a certain set for blood pressure cuffs, weight scales, etc. We try to keep our vendors very narrow in what they can use, even though the vendor would tell you, oh, we can, connect to 1,500 devices. That's well and good. But, if you have patients who ad hoc say, I have a device at home I purchased on my own, and I want to connect, and I want it to go through my chart or whatever portal, and I just want to give that information to my doctor. But we're not actively managing it. We're not actively monitoring. And then there's the active group where they're enrolled into a program. They've got an FDA-approved device. It's standard across the organization, so that's what we use. So we know the data that comes out of it is going to be calibrated to that device. But the biggest thing you still have to worry about is variability in how people use the device, right? There's no way of me knowing that the patient I enrolled is the one standing on that blood pressure, on that weight scale, or one taking the blood pressure reading, right? So there has to be trust on the patient side that they're obviously sabotaging themselves if they falsify the data. Then on top of that, there is a signal to noise ratio you have to think about. What data is really meaningful and what is just noise? And so you never want to treat someone just based on 1 reading or 2 readings. You want to see what the overall threshold, what the mean average is or trend is over time. Just like you would a diabetic or a hypertensive patient, right? Because if you overtreat, you may drop their blood pressure, or maybe they're having a bad day. Maybe they're, got told they were fired and their blood pressure's up that day. Well, you might want to talk to that person first before you start increasing the medication. So that's an important part. The other piece that's been challenging is the supply chain and logistics around it. If you start, we have 1.2 million people that come through Prisma doors every year. And let's just say 10% of them get into an RPM program. Well, that's a lot of people. And they may be on various different programs. They may be centralized or decentralized in regards to management, as we talked about earlier, Mark. And then, how do you get the devices out to them? How do you manage those devices? Who supports those devices? You have to outsource some of that, because typical function within the IT departments of health systems are not to troubleshoot wearable devices, at least in our health system, maybe at others. And then it's important to make sure that the patient's compliant with the use of the device. So you don't want to just get a device and let it sit in a closet. And that's why we built in alerts that says, hey, Mr. Smith, you haven't taken your blood pressure for the last week. Can you start taking it? Or let's find out what's wrong. Is he taking it and the device is not connected, and hence we're not getting any data? Right. So there was a question earlier around, billing and coding and chronic, and a lot of this comes around chronic disease management codes, which you require at least 16 readings in a 30-day period, 30 to 31-day period. That has to be reviewed, and then you can bill for that kind of code. But that's not always the focus of most health systems. We're looking at it from a value-based care perspective, right, as well, and getting people to their goals.
Right. So we have three really excellent questions, which I want to get to right away. But first, let me just ask both of you, what about the data analytics of this? That's complex too, right? Because you have to decide, first of all, you have to decide which data to even analyze. As we were talking about a moment ago, Dr. Herton, you could have patients, patient-facing consumer-based devices of all different kinds. And so, that kind of creates a headache. Real quickly from both of you, what are you doing so far around analytics? Dr. Herton, do you want to go for a second?
Yeah, so I'm sort of a purist in this way from the research perspective, where I think a lot of this stuff we have to always take down to that kind of ground level and first say, okay, what are the markers that we think map to whatever we're looking at? Then once you identify those markers, you really need to validate them. It's one thing just to show that they work in, say, a small group in a study, but you need to validate them and be sure that they actually hold up to, external scrutiny in another kind of group or cohort. And then once you've done that, you can really then start operationalizing it. Now you have some confidence that what you're looking at is important. So the analysis that what we're doing at each of these levels is we work very closely, obviously, with our statisticians, trying to use machine learning algorithms to develop these predictive models in each of these cohorts and validate it, and then take that to the final step of operationalization of it. Because it's a big thing, and our physicians are also quite busy with patient issues and taking care of their patients, phone calls and messages. So you want to make sure if you're alerting doctors that say, Mrs. Smith is not doing well, that your thresholds are sort of correct and you feel really confident that what your alerts are meaningful for both the patient and the doctor. Because if you get it wrong too much, both the doctor and the patient can lose faith in the system and say, well, I'm getting a lot of false alarms, or, and it's not materializing that I'm actually getting sick or something. So right, in some of these chronic diseases, that's how we've sort of been looking at it and been very cautious with, not overstating the abilities yet of where the science is for us and some others too.
That makes sense. And Dr. Patel, your thoughts on analytics?
I think is an integral part of population health. And for me and our system, it's about not only the individual patient and how we get them to their goals and look at that data and surface it when it's the right time, to Dr. Herton's point, and not have a lot of those disruptions that don't matter, but also to community-based healthcare. So if you think about folks living in certain communities where you have high prevalence of certain disease, it's important to look at that data not only from individual level, but at a community level. How is a particular subset of group of people doing in an area? Because what you find through research is that they influence each other in a community. And that's why, hypertension may be high or diabetes may be prevalent in a certain community. It also goes in line with socioeconomic and those social determinants we talked about. In a certain community may have more challenges versus others. So the use of data, it has to be, you have to be very strict in understanding what your principles are around the use of that data, what your data models are going to be like, what your actions are going to be like, in order to be successful in that. And as part of that, I think you have to start to add automation, because if you start to have more and more patients enrolled in RPM, you have to have some sort of automation built in through AI or machine learning of when to, and maybe that's how you teach the system to take that noise out. So the system tells you only what based on previous learnings, what is important to actually ping a patient about or reach out to a provider about when that happens.
Yeah, and again, I think we're very early on in all of this. I'm sure both of you will agree. What I think will be exciting is, as you know, as you mentioned, Dr. Herton, like you're starting to collect data. It'll be really interesting as certain provider organizations do studies and publish them about what they've learned, what's important, and some templates will be created for other providers then to follow in your footsteps. I think that will be very exciting. So we have three great questions, and all of them I think involve slightly complex discussions. So I'm going to head into the questions. So we have a question from Dr. Arlen Meyer, who was actually one of our panelists last week. So I really appreciate it, Dr. Myers. So he says, we have the technology. What rules, regulations, and dysfunctional existing systems need to be changed to determine when and if wearables add value and how we increase dissemination and implementation for those that do? One could go in a number of directions. Dr. Patel, do you want to hit that one, and then we'll go to Dr. Herton?
Yeah, that's a great question. Rules and regs around RPM continuously change. Our CMS has been leading a lot of these efforts around reimbursement and promoting those and what's included, like I said, about 16 readings in a month, et cetera. But the technology continues to change. And one thing we've all seen during this past year and a half is the M&A action consolidation of even healthcare companies. So where you may be going down one path, you may have to pivot because that may not be the path they are going to continue on after a merger and acquisition occurs. In regards to dysfunctional existing systems, there's a lot. Because it's hard sometimes to integrate these solutions. There's a lot of them out there. There's a lot of RPM companies out there. And what you're trying to find is, okay, we know we want the data to be in our EHR. We want the master record to be there. We want the engagement to be there in regards to documentation and change of meds, et cetera. But getting to that point is difficult sometimes because some of these RPM vendors are relying upon custom integrations and build at the health system side. And so there's not something that you can just pick off the shelf and tweak to meet your needs. A lot of these apps are going into the App Orchard now or Smart on Fire applications and either EHRs that are out there, the major EHRs that are out there, which help with that conversation and integration. But the biggest thing I would say to prevent dysfunction is to make sure that your health system altogether is lockstep in the vision, meaning Dr. Herton may have great things that he wants to do in GI and rheumatology and other and subspecialty, but let's make sure that Dr. Herton uses the same platform that we're using in primary care or in another area so that the data is uniform. So you're not having to juggle different systems in order to have the singular data set. And I'm trying to read some wearables add value and how we can increase dissemination implementation. I think that the biggest piece there is just start with the data, start with the understanding of what your need is as a health system. I think all of us understand the move towards value-based care, and we are getting data of how our providers are doing in management of chronic disease on our network scorecards, et cetera. So what we've done is instead of trying to invent our own thing, we work very closely with our service lines to understand what are their goals as that service line and making sure that we flex our programs to meet those needs. Because at the end of the day, it's not about the technology, it's about what the outcome is going to be. And we all have to be in the same, looking in the same direction in order to execute and be successful.
Terrific. Dr. Herton, your thoughts on that?
No, I completely agree with what Dr. Patel said. That was really well put. I think this idea, I'll focus on that last part of adding value. I think that's very important because sometimes we get caught up in these technologies where we say, all right, we can do this. We can identify or predict something that's going on with diseases, but does it actually add value either to the patient's management and change outcomes or anything compared to what we were doing before? So we always want to be sure what we're instituting and having patients and doctors use does add that value, as you mentioned. And this gets to the point of not only identifying the markers that are important, but then also, clinically, how is this actually affecting patient care? And are we actually making meaningful outcomes on that? And if that's the case, then it kind of deserves wider spread distribution and use if we're actually modifying the disease or improving health in our systems and in the country.
Yeah, absolutely. So we have a question from Diane Worth, and she says, in the RPM arena, my understanding is that only BT-enabled device input is permitted when using the RPM billing codes. Is that correct? Unable to bill RPM if they are using their own wearable and inputting data is not covered. That's way above my pay grade. So I'll ask you, physicians, do you know whether that's correct or not?
Yeah, a lot of the CCM codes are built around not just the data coming in, but having actionable results of what you want to do there and engaging with the patient. For example, a chronic disease management code has multiple variations. One is the first initial setup. So yes, we give FDA approved Bluetooth connected devices, not saying retail use. Now, unless that retail device is FDA approved and one of the compatible devices that your health system approves, then you can bill for it so long as that you're getting that data into your EHR, you're analyzing that data, and then you're giving treatment plans based on that data and circling back with the patient at least once a month and requiring at least minimum 16 days. Now, under the current PHE or public health emergency, you don't have to have 16 days. It could be a lot less than that, but we continue to focus on at least 16 days of minimal data. And you have to have a care team that reaches out and engages and writes a note on the patient on what you did that month. Here's the average, here's a change, maybe no change, and here's education around it. Then you can bill for it. So there are definitely documentation requirements, but your billing and coding folks would be very good and instrumental in helping you guide you in that direction.
Thank you. Dr. Hurton, do you have any additional insights there at all?
No, that was
okay.
Yeah.
Appreciate that, Dr. Patel, because I would not have known the answer. So we have a question from Pankaj, who asks, cloud providers like Azure or AWS have now specialized offerings around IoT/wearables device management, and they take care of end-to-end journey, starting from device provisioning to data monitoring and predictions. Are we going to see a jump in cloud adoption by companies working in the remote monitoring space? That's Pankaj Oja. I hope I said his name correctly. Which of you gentlemen would like to? This is a little bit of a complex question, so take it as you would like.
Well, I think the simple answer is yes. Everything is going to the cloud. And really, it depends on who you've partnered with AWS or Azure or many of the others that are out there. Or are you going to do it yourself? A lot of health systems have built their own data lakes and have a massive data team that does it themselves. And so it just depends on how you want to do it. I think there's going to be a hybrid approach, because I think that provisioning of the devices, collecting that data, especially as you expand, it's very important. There are major health systems out there that are doing it themselves, but they have the resources to do it. But there are other health systems that won't have it. So yes, you will see a great adoption of cloud, and just in general, not only for RPM, but for pretty much everything.
Dr. Hurton, do you have any thoughts on that at all?
No, I agree completely. I think, as mentioned, it's going to be a hybrid, and it's going to depend on the specific health systems and the organization with regards to what resources they have internally versus would want to use from a cloud-based service. So I think it's going to be a hybrid, as Dr. Patel mentioned.
That makes sense.
Yeah.
That really makes sense. And we have a question from Salvatore Volpe, who says, how to address the digital divide from lack of broadband? Is it rolled out with the RPM as needed? How to ensure that these devices maintain security updates and not permit attacks to the networks of private users? Is technology like blockchain a must-have or a good-to-have? I think that's a really interesting question. One of the unresolved questions is how any devices that are external, meaning not created and maintained by health systems are going to handle these questions. As you know, certain kinds of external devices actually fall under the aegis of the FDA, and it's like a different set of rules from the HIPAA rules. So this is a good bundle of questions. What, doctors, any thoughts?
I'll take a stab at it. I think I touched on broadband earlier. There's a significant population in South Carolina that does not have access to broadband or even smart devices. So like I said earlier, we try to package in a connected device, and our goal is to do that. We haven't picked a vendor we're going with there yet, but we want to have a device that's locked down, secured, managed by us through an MDM, that will have the RPM solutions or other apps that are required on that device, and it will be cellular enabled or LTE enabled or 5G enabled. But we're also working a lot with the FCC on the expansion of broadband. There's some amazing projects going in the state of South Carolina and across the country, because the FCC has actually put a lot of money out there for broadband expansion. And so, that is one piece that we're definitely very sensitive to, because we find a lot of our patients who are on the lower socioeconomic scale are also the same patients who have uncontrolled disease. And so we have to sometimes make sure that we have all the right equipment, but also improve tech literacy. It's not about just giving technology to people, but make sure they understand how to use the device. That's especially in the elderly population, that is very imperative. They may have connectivity, they may not know how to use it. So tech literacy and education is part of it. In regards to security, absolutely, that's top of mind. And this is why we don't allow just those over-the-shelf sort of apps that people have that connect data to the EHR. We're very prescriptive on how we do that, because we're sensitive to that. And obviously, you can see the news about all the ransom things that are happening. So we're very aware of that, and cybersecurity is a very top of mind. Every single application that goes through our organization has to go through our InfoSec that get approved and we've tried to make sure that everyone is HITRUST certified in regards to their applications. In regards to blockchain, I think that is something that will take off in healthcare. We're just investigating it at this point, but it's something that we are thinking will help the situation as we move forward, but more to come on that.
Yeah, great comments. Thank you, Doctor. Dr. Hurton, do you have anything to add to that?
Yeah, I think the digital divide comment is really important. And this is not only in clinical care with digital tools, but also in the research that surrounds them and how we're coming up with different algorithms or approaches. Because it's both people who might not have access to smartphones, and then also people who aren't maybe used to using wearable devices or smartphones, which limits the data that we might be collecting as we're doing these studies, but also in trying to implement it in some of our more vulnerable populations in our health system. So that's a huge issue. And I think there's a lot of focus on ways we could try to get around this. And I focus more on the research aspects of this. And many of our studies, we're giving out the technologies, if we're doing any of these studies, to try to compensate for that. Smartphones, devices, we're providing to people, paying for the cellular plans, to try to really assure that we can kind of overcome that divide as best as possible.
Yeah, thank you. Thank you very much. Great. So we have just enough time now. I'd love for us to end with each of you doctors sharing with us two things. One, advice for those who are beginning on their journeys in their organizations in this area, because I think it's such an exciting area, but one, as we've been discussing here, that has so many challenges and complexities. So advice, and then also kind of a prediction, what will this landscape look like in a couple, 3 years from now? Will it have moved forward significantly? Will we have kind of a more standardized, clearer picture of what we're all doing? Or will we still all kind of be trying different things in different ways? I keep, in this discussion, I keep thinking about, I'm kind of fascinated by the early history of technologies such as cars, telephones, etc. And when you read about the early history of cars and telephones, it's quite fascinating. Things were very chaotic at first and very confused and jumbled. The first cars were all custom built. And so literally you would have the brake in a different place, or it would look different fundamentally. And, you know, you would, even the primitive dashboards they had in the first cars would be completely different. So it kind of feels a little bit like that right now in this area. So each physician, I'll ask you to share advice and predictions. Dr. Patel, do you want to go first?
Sure. I would say my biggest piece of advice would be to start with the problem first and look at your health system and where you are when it comes to your chronic disease management. Look at your data. Look at where you are from a networking standpoint when it comes to control of some of these disease states. I think the second piece of that is making sure that you have engagement of your particular service lines where you may be starting. So going and talking to your primary care service line leadership or your subspecialty leadership and understanding could we do to get patients to their goal faster, and what are the challenges that they're facing around it. And then in choosing technology, you want to make sure that it's integrated into your EHR. You want to make it easy for the providers to use, because you want technology to be the least disruptive for providers as well, not to contribute to their burnout that they already have around other use of technologies like EHRs. But you want to make it easy for them. You want to give them a tool that augments the care, right? It's not an additional task. It's something that's going to help them be better doctors or providers. The other piece is to make sure that you understand and set rules around escalations, what your inclusion criteria is going to be for a certain program, and who should get alerted and when. Kind of going back to earlier discussion around that hybrid approach from centralized versus decentralized alerting. A provider may say, I want to know and do everything, or a provider may say, I want digital health to handle everything and make sure I get the data, and helps enable their care for that patient. In regards to the future, I think that, and I hope, I would say, is that technology is going to become more ambient in its stance. And what I mean by that, kind of going back to what the title of this webinar is, around true wearables. And so wearables right now are IoT devices, the things that you slap on your wrist or your arm or things of that nature. But imagine if your T-shirt or your contact lens or things that you just put on normally have sensors in them, the size of grain of sand, that measures your blood pressure, that measures fall detection, that measures your blood glucose. How about the soles of your shoes, that just because when you stand, it tells you your weight? Or how about the welcome mat that you have, or some other mat that you may have at your vanity? When you stand there, it tells you your weight. So you don't have to go physically pull a weight scale out and stand on it. You don't have to worry about putting a cuff on to get your blood pressure. So I think ambient technology is going to come into play. I've got to go and see some amazing technologies from some amazing next generation technology vendors around sensors that are so small that they can be impregnated into clothing and other things that we do every day. You can see what the Apple Watch has done around AFib and what they're thinking about diabetes here in the next version. So I think that's the future. And then I think that what will happen with that is that you'll have more engagement, you'll have more adoption, because it's just invisible. It's not asking a patient to do anything additional. It just happens, and it just works.
Terrific. Thank you so much. Dr. Hurton, would you like to also share advice and thoughts about the future?
Yeah, I think for advice, so I agree completely with the advice that Dr. Patel was mentioning, which is very problem-based, focused.
Yeah.
Additionally, I would say, though, if you're starting to think about using wearables in your clinical care, it really comes back to the data and the device. So you have to be very confident that the data is actually reliable enough from which these algorithms are based on to warrant the triggers that are going to be coming into your clinical care. And also, we talked about the variability in these devices. So you want to be very sure that the device also is measuring what we think it's measuring accurately compared to whatever the gold standard is. So really the quality of the data and the quality of the devices are really paramount, and to do the due diligence with those before instituting them more broadly. My prediction for the next 3 years will be that these large tech companies, I think, will become increasingly visible in this space with wearables and as it relates to health. And as Nick had mentioned, we've really seen this particularly with Apple starting to get into the AFib sphere, thinking about glucose and diabetes, and then now with pulse oxes in their watches.
Yeah.
We're speculating will we be doing blood pressure monitoring as well with devices like the Apple Watch. So these companies have really demonstrated this interest, and I think my projection would be in the next few years we'll start seeing a lining of some of these commercial devices, perhaps with health systems as their device becomes used on a broader basis.
Yeah.
That's speculation, but it seems the way the trend is sort of going with these companies' interests.
Yeah, I completely agree with you, Dr. Hurton, and I agree with you too, Dr. Patel. I think the way I would summarize it is we're very, very early in this. And I think what we're going to start to see is we're going to start to see the landscape self-organizing itself, right? Look back 10 years ago to what population health management was. And it was very similar to this in general. Like people were trying to figure out what they were going to measure, how they were going to care manage, who they were going to care manage, under what circumstances. They were organizations were just starting to do broad health risk assessment of populations. And that's kind of where we're at in this space. I agree with you, Dr. Hurton. I think one of the things what will become templates for other organizations to follow. And over time, more standardized approaches will emerge. So I want to thank you both very much. Also, I just got a message saying my internet connection is unstable, so I apologize. I might suddenly disappear, which would be very unfortunate a couple of minutes before the end of the session. So I just want to thank you both very much. I think that this is a very exciting time, and I think that I'm looking forward to the next few years as innovative organizations like yours move forward. Again, thank you very much, Dr. Rob Hurton and Dr. Nick Patel. You've been fabulous, and we appreciate it so much, and we appreciate the great questions from our audience. So thank you both very, very much. And Matt Rayner has magically reappeared.
Thank you, Mark, and thank you, panelists. What a great way to kick off our patient engagement virtual day. We're going to take a very short break. We'll rejoin back here at 11:30 Eastern Time for a fireside chat on delivering better patient experiences with an always-on approach. So don't go too far. We'll see you back on here at 11:30. Thank you so much.
Thank you all.
Thank you.